Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Carrie Holland, and the managing editor for Infectious Disease Clinics here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic related to infectious diseases. Today, we will be discussing the recent June 2023 issue dedicated to sexually transmitted infections, guest edited by Dr. Jean Marazzo. Joining me are consulting editor Dr. Helen Boucher from Tufts University School of Medicine and guest editor Dr. Marazzo from the University of Alabama at Birmingham, Heersink School of Medicine. Hello to you both, and thank you for joining me today.
Helen, it's wonderful to be able to talk to you today about one of my favorite topics, which is the whole group of sexually transmitted infections. And it was really fun to put together this issue of ID clinics. And I was reminded as I was doing it with you that it had been at least 10 years, I think, since we did the last version of this clinics on STIs. And as I talk about in the preface to this clinics, it's been over 20 years since the Institute of Medicine published the big report that was entitled The Hidden Epidemic Confronting STDs. And one of the impetuses for doing this edition was to sort of do a check-in and say, how far have we come? Have we really tackled some of the main problems? And I think if there's one message that I would love people to take away from this is that there have been a couple of gigantic successes, but by and large, we are not doing very well at all with what is really a syndemic of sexually transmitted infections, and in particular HIV. And as we are going to talk about in detail, and as I highlight in the preface, some of the major themes are continued antibiotic resistance, of course, a topic that you have been incredibly eloquent about and an advocate for throughout your career. And the things we worry the most about, of course, in that regard are gonorrhea, but also Mycoplasma genitalium, which is giving us a lot of headaches in terms of management. Syphilis is completely out of control, and we can talk about that in depth. And then the last depressing thing I'll mention, and then I'll mention one big success, is genital herpes, which still afflicts an astonishing number of people, still is probably the biggest driver of HIV if you look at synergistic interplay between those two viruses worldwide, and really doesn't have new therapeutics or new vaccines on the horizon. So before we dive in, I'll just say that vaccination for human papillomavirus, genital HPV, has probably been the biggest home run and has the potential to really change the trajectory of many, many cancers globally. So I'll stop there and turn it over to you and look forward to talking about things more.
That's great, Jeannie. Thanks so much for being here and for leading this really great edition. Let's start with the success of the HPV vaccine. It's very near and dear to me. I lost one of my fellows 10 years ago now, very aggressive cervical carcinoma. How are we doing with uptake on the HPV vaccine in America?
Well, we could certainly be doing better. And unfortunately, a couple of threads have aligned, I would say, to prevent the potential for this vaccine to truly change the trajectory of cancer. So first of all, you may remember that when the vaccine was initially marketed, it was really marketed around the fact that HPV was a sexually transmitted infection. And unfortunately, that, I think, made it look, especially to many parents who were being asked to consider the vaccination for their kids before they became sexually active, made it really look like something that could be otherwise avoided, i.e., by sexual safety measures such as condoms or monogamy or delaying the onset of sex. And so that really impacted a lot of decision-making by parents to not embrace this. And it's taken a long time, I would say now, since its introduction, at least a decade, to sort of get around that initial misconception and rebrand it as what it is, which is really a cancer vaccine. the complete disappearance of genital warts, particularly in places where the vaccine has had great uptake. Australia and Scandinavian countries are probably the best two examples. I mean, Australia has essentially eliminated genital warts as a consequence of the vaccine. So it's really pretty remarkable. In the United States, the uptake has been good, I would say, certainly above 50% in young people. But again, it's really, really not as good as you would like. So I think it's promising, but as more word gets out about what's happening in some of the other countries that have had even more impressive uptake, I'm hopeful that it will continue to grow. There have been a couple of papers now, most recently in the New England Journal, looking at long-term effects, meaning over the last decade plus to 20 years, of uptake, showing unbelievable declines in every stage of cervical neoplasia. So all the way from invasive cancer at the end to precancerous dysplasia, which is just an amazing phenomenon. The other thing I should mention is that the fact that a lot of the initial emphasis was on women for cervical cancer, I think also obscured the fact that this vaccine has the potential to prevent a large proportion of oropharyngeal cancers, particularly in men. And we do know that those are on the rise. And I just saw something about this in the last week recently, probably because of the gap in young men not getting HPV vaccine as early as they might have when it was first introduced. So long answer, but, hopeful, particularly when you think about places where cervical cancer remains a major cause of female morbidity and mortality, when you go into some countries that have not had access. So I'm hopeful, but, the whole vaccine resistance issue has been at play here, especially around the issue of sex and initiation of sex in young people.
Yeah, thanks for that. And I'll just put in my pitch, as a transplant infectious disease person, we see many people coming to transplant evaluation who have not been offered this vaccine. And it's really important to offer it because those individuals, when they get a transplant, have a much higher risk of cancer of all kinds. And this is a preventable measure that works. So great. So let's bridge now to the more challenging areas and start maybe with herpes, because I wanted to ask you a question about herpes. You said there hasn't been much progress on a vaccine. And, just recently I've been reading some encouraging news about a potential vaccine for one of the herpes viruses, Epstein-Barr virus, which it looks like there's a couple of technologies that are advancing. And I wonder if that makes you any more optimistic that we might see another pass at a HSV 1 or 2 vaccine anytime soon.
It does. I mean, I think the success with mRNA vaccines and also the use of AI in potential target development. There was a great paper that just came out yesterday in Science on the use of artificial intelligence in infectious diseases. And they actually do talk about this very thing, which is sort of trying to look at immunogenic targets in ways that are completely novel and really are not possible with in vivo or in situ systems. I do feel like it is going to be a probably period of great promise in the next 10 years. I think especially if we could get a vaccine against one of the other herpes virus, right? There's CMV, EBV, Kaposi sarcoma associated HHV8, and now NHSV 1 and 2, as well as VZV. So, we've done well with VZV for reasons that are kind of too complicated to go into, but I am hopeful that there will be something coming forward. It's just been very, very disappointing. There also are people who are pursuing therapeutic vaccine. So that would be not a preventive vaccine, but for people who, really are either resistant to management with the available drugs we have. And I should mention that one of the worst things about herpes is we have had no antiviral therapies that are new since I was a fellow. And that's a long time ago, right? Acyclovir became widely available around that time. And then very shortly after, famciclovir and valacyclovir. But we have had no really very good tolerable, I should say, therapeutics since that time. So, I'm hopeful that there will be something in pipeline, but it's going to take some time.
Yeah. Oh, well, thanks for that. So, let's turn now to bacteria and resistance and talk a little bit about gonorrhea, which is getting some attention in the press, and the resistance issue is a little bit frightening, actually, to those of us in this business. And tell me where you stand on this and where we should be paying the most attention.
Right. So just as a reminder, people tend to think of gonorrhea as something that happens to other people, something to happen to people who, go to STD clinics, but it actually is the second most common bacterial STI in the United States. And if you look at the numbers globally in 2020, there were over 80 million new infections globally. So it is not an uncommon infection. The big concern is what's happened in the last 10 years, which has been continued emergence of antimicrobial resistance, gonorrhea. If you look at the trajectory of gonorrhea's ability to evolve antimicrobial resistance since its introduction of penicillin in the 1940s, it's basically gone through every single class, including the penicillins, the tetracyclines, the sulfa drugs, the quinolones, which were sort of a holding option for several years, to the point where we now have only one active class, which is the cephalosporins, and to the point where we have to give those cephalosporins parenterally for optimal management. There are some other drugs under study. Zoliflodacin is one that I think has at least a hope of getting out there. There's a phase 3 trial that I think is completed, so should actually perhaps give us some options soon. But not only are we facing the fact that we've got to use a parenteral agent at an increased dose, by the way. So one of the big points of the paper that is the nice review that was done in our clinics is that the CDC treatment guidelines actually increased the dose of gonorrhea recommended for routine genitourinary infection to 500 milligrams IM and more for people who weigh more, so a weight-based approach. So not only is that an issue, you've got to give people a shot, but you also are starting to see, and just this past year, we saw for the very first time in the United States, infection in Massachusetts, your home state, with an XDR isolate, extensively drug-resistant isolate. And that has been seen in places, Hong Kong, actually Canada, Scandinavia, Europe previously, but this is the first time that cases have been detected in the United States. And interestingly enough, there were two people who had this isolate, they had not reported any travel. So it wasn't really clear, where it came from as a point source kind of origin. And what's very worrisome about that is that it suggests that the strain is probably circulating in our sexual networks, which is not surprising at all. Given the spread at which pathogens can now kind of traverse borders very easily. So that says that people really need to be vigilant about the potential for treatment failure to represent more than just sort of a fluke. If somebody has failure of their symptoms to resolve, or you have repetitive recovery of an organism in a patient, then you really have to get very concerned. And you do need to involve the public health authorities and microbiologists to try to characterize this isolate. The good news about the infection in the Massachusetts patients was that it did respond to a dose of ceftriaxone. So it did clinically respond, but it was clearly very, very resistant and very worrisome. We don't really know. When we look at, the CDC has a very nice gonococcal surveillance product that collects mostly isolates from men in STD clinics from the urethra. So it clearly favors detection of the epidemiology, not only in men, but particularly in men who have sex with men, given the demography of who goes to those clinics. And when you look at those isolates, patterns of those isolates, you still see that there is a overall good susceptibility to ceftriaxone. So I think it's reassuring, but we really cannot rest on that. The other thing I'll say is that there are people who have been advocating for a long time for point of care diagnostic tests. And there's a great chapter in the clinics by Mauricio Khan and Bobby Vanderpool that talks about emerging tests and why we really, for STIs in particular, need to develop point of care tests and what some of the cooler things that people are looking at are. One of them is a point of care test that could give you a quick read on whether the isolate is susceptible to an oral agent such as a quinolone. We don't use drugs as a recommended therapy when more than 5% or so of resistance of isolates are frankly resistant. That still means that quite a lot of infections could be treated with the drugs that are no longer recommended. And if you really had sort of a good triage mechanism for assessing in the patient what that isolate was likely to be susceptible to, you might be able to wield more of your armamentarium than we can by just presumptive therapy, which with what we know is going to work. Those are some of the concerns with gonorrhea. I'll also mention that still see a fair amount of infection in women, and we still see a fair amount of disseminated gonococcal infection. I've seen quite a bit in the last year or so, at least in Birmingham. We've admitted a few patients to the hospital. So a reminder to learn about sort of some of the classic manifestations, the classic tenosynovitis. Remember, don't misdiagnose the young athlete who happens to have a diagnosis of a sort of a strained ligament when in fact they have inflammatory tenosynovitis from their disseminated gonococcal infection. Also the rash and arthritis. So definitely out there and also increasing. So the numbers are not going in the right direction.
Yeah, thanks, Jeannie. And you hit on a couple of things I just want to highlight. So the diagnostic, so important, and yet we still have barriers, right? We still have barriers to developing diagnostic tests because we have two separate pathways in the FDA, and we have two different regulatory processes, and then we have pricing and reimbursement issues for the way hospitals and clinics are remunerated for care of these patients. So advocacy and policy work to do there. And then the surveillance, you highlighted surveillance data, which is vitally important to understanding the problem. And we are benefiting still from the increased infrastructure at the local and state level in public health that was ramped up for COVID. Absolutely. And it's really important that that's not ramped down. And so there's legislation being debated in Congress right now, pandemic preparedness legislation that actually gets at some of this. And it's just so important for everyone to know that if you're asked to advocate, if you're asked to sign a letter, you should do it, click the email and sign it, because if we lose the infrastructure that we have that isn't perfect, we'll have even less good surveillance data to understand where the problem is and to be able to intervene at the right time. So thanks for highlighting those really important points. Let's talk a little bit about Mycoplasma genitalium. That's one that I think a lot of us who don't do STI care as a routine don't think about as much. So maybe you can just highlight the don't misses and what the big challenges are.
Mycoplasma genitalium is something I think of as chlamydia's little sibling. And I say that because when you think about the spectrum of clinical manifestations, it's very similar to chlamydia. So it can infect the cervix in particular in women, and it infects the urethra in men. It rarely infects the pharynx. It can cause proctitis or rectal infection, but you really want to know that it is a cause of urethritis in men, and primarily men who have sex with women. It is been detected and it can occur in MSM, but it's largely, at least at this point, in men who have sex with women. And the problem with this pathogen is that antibiotic resistance is really widespread. So more than half of infections are resistant to macrolides, and we're seeing an increase in fluoroquinolone resistance. And so what the CDC recommends is resistance-guided therapy for symptomatic patients, meaning you initially want to treat people with tetracycline, namely doxycycline, recognizing that that's probably not going to eradicate the infection, but it's going to reduce the organism load. And then ideally, you want to know if it's sensitive to macrolides to go forward with azithromycin or moxifloxacin if it's macrolide resistant. Now, the majority of practitioners have no access to antibiotic susceptibility testing. And that gets back to your comment about how challenging it is to get these needed diagnostic tests through the approval process and where we need them. So what's happening in practice and what's recommended if you don't have access is essentially you start with doxy, and then you go ahead, and if you have access to moxifloxacin, you go ahead and do it. The challenge is that it's not going to stay, I think, sensitive to moxifloxacin either, because we are already seeing that 10 or more percent of strains carry markers of potential fluoroquinolone resistance. So it is really going to be an issue. I can tell you that we have had a couple of patients. In fact, you may, in your work as somebody who takes care of a lot of immunocompromised people, know that mycoplasma infections can take advantage, particularly of people who have disorders of gamma globulin, right? So hypogammaglobulinemia. We had a young man who had immunoglobulin deficiency who ended up getting infected in the urethra and then a seminal vesiculitis with Mycoplasma genitalium, horrible continued resistant infection. And we ended up having to get pristinamycin for him from France, actually, to treat him. And that did resolve the infection, but it was completely resistant to everything else. So it's one of these like stealth pathogens that doesn't seem to cause a huge inflammatory syndrome, kind of like not like gonorrhea. You're not seeing a ton of pus, although that doesn't always happen with gonorrhea. And then the other thing I should mention is that it does ascend in the female reproductive tract. So it can cause endometritis, probably pelvic inflammatory disease for sure. We don't really know what the burden of sequelae in the female reproductive tract is. Like we do well for chlamydia. We know that chlamydia is the major cause of tubal infertility, chronic pelvic pain, ectopic pregnancy, all those things that are chronic pelvic infection. We don't know how much Mycoplasma genitalium contributes to that, but I think it's better not to find out if we can. And that's never true. You want the data, of course. I mean that facetiously, but it is probably a player in those processes. And so another reason you really want to try to get a handle on it if you can. But I think for people in practice who may not specialize in this area, what you should know is that a man with recurrent urethritis, we often think about trichomonas and you want to treat presumptively for trichomonas, especially again in men who have sex with women. Anaerobes, a big one if men are having insertive anal sex for sure. But in the absence of those two things, absolutely think about Mycoplasma genitalium and know that there's a nucleic acid amplification test that of course can detect gonorrhea, chlamydia, and MGen. So we're in good space with that, and that's widely available.
That's great. Well, we're just about going to be out of time, but I kind of saved one of the best for last. We're seeing, I think all of us are seeing this, I don't want to call it a paradox, but interesting phenomenon of more STIs in our well-controlled HIV patients. And, we've had the you is you movement, right? Undetectable, you're not going to transmit, but that has led to seeing more syphilis, gonorrhea, and other things in our HIV patients. So what's your advice to this population?
To the patients or to the providers?
Both.
I am so torn, like many of us, between being so thrilled that people can have a sexually healthy approach to life after the, sort of horrific years of pre-antiretroviral therapy and even pre-PrEP. The thing is that, everything comes at a cost. And unfortunately, the epiphenomenon of syphilis, gonorrhea, and even chlamydia in people who are living with HIV or using pre-exposure prophylaxis to prevent HIV, again, all of it goes without condom use. And there's absolutely great data to suggest and to confirm that that's what's going on. So the side effect of that, of course, is exactly what you're seeing. And when you look at, we'll just talk quickly about some of the data for syphilis, because if you haven't been tracking this, you will be forgiven for not knowing that the syphilis numbers are off the charts. In fact, we're seeing numbers that are higher than what they were in men who have sex with men in the pre-HIV era. It's really, really remarkable. And it's not just men. And I think that's where people have finally woken up in the last couple of years. So when you look at least early syphilis, men who have sex with men account for well over half the cases. And of those, at least 40%, sometimes more, are HIV co-infected. It's not, unfortunately, limited to that population, and the rates of congenital syphilis, and I will come back to your question, I will give you some advice. The rates of congenital syphilis are just surging off the maps. And in fact, in 2021, there were 2,600 cases, which is 184% increase from 2017. So that's a lot of neonates that are very affected. And that doesn't even count stillborns or miscarriages. It may count stillborns. Spontaneous abortions are not counted there. So all that to say, and that's on top of a shortage of benzathine penicillin. You may have seen we're limiting our benzathine penicillin. In fact, people are being treated with doxycycline for their primary syphilis as a first choice, even though it's an alternative therapy, because we're running out of benzathine penicillin. So my first piece of advice is if you can manage not to get it, manage not to get it. But the challenge there is that most people are being infected with syphilis without an obvious source. So symptomatic partners are really in the minority. So yes, of course, if somebody has a chancre or an obvious rash, it's a good thing to take a look. But that is really not going to get you very far. I think the answer right now is frequent screening, and make sure that if you're in HIV care, then you really want to engage with your provider about sexual health, right? The days of HIV providers just worrying about the viral load and just worrying about prophylaxis are over, and they should have been over a long time ago. And I think to their credit, many people have changed. But routine sexual health care has to be part of living with HIV, again, regardless of what you're doing sexually and where you live and who you are. And then for people who are using pre-exposure prophylaxis, you got to recognize that you are going to be at increased risk for all of these infections, and you got to know what's going on. And again, seek testing. We're using, the 3-month sort of periodicity. That's a lot, but you can do self-testing. The FDA has approved that. There are places you can go to just test yourself, test your pharynx, test your butt, test your urine. So all of that works. And again, unfortunately for syphilis, you've got to get a blood sample. So coming back to that great point of care assessment, what we really need is a combined PCR. I think a multiplex PCR for Mpox, syphilis, and herpes. That would get us so far along the trajectory. So I know I've gone on very long because I am a little passionate about this stuff, but you knew I would be.
Oh, it's great, Jeannie. Thank you so much for a really excellent addition, a great update, a great discussion, and for all your leadership in this space. Really appreciate it.
Thanks. It was a pleasure to talk with you.
Thanks so much for taking the time to talk about the issue today, Dr. Marazzo and Dr. Boucher. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on sexually transmitted infections, visit us.elsevierhealth.com/expert. Infectious Disease Clinics of North America is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter @ClinicsReviews and @IDClinics, and subscribe to the Clinics Review Articles podcast wherever you get your podcasts.